Welcome back. Today I want to walk through a framework that I use all the time when I think about injury recovery, especially in occupational medicine, sports medicine, and general musculoskeletal care. And that is this idea that most injury rehabilitation falls into three phases. First, the structural phase. Second, the motion phase. Third, the strength and function phase. And that matters because one of the easiest ways to get rehab wrong is to push the wrong goal at the wrong time. If you try to strengthen tissue that is not structurally ready, you create problems. If you try to return somebody to function before they have adequate motion, you create negative compensation. And if a patient stops progressing, one of the most useful things you can do is not just keep barking up the same tree, but step back and ask whether you have missed something in the phase before.
A civilized approach, really. Instead of treating rehabilitation as one giant, undifferentiated bucket of go to therapy and hope for the best, you are arguing that recovery has a sequence and that each sequence has a job.
Exactly. And if you understand the job of each phase, it becomes much easier to make treatment decisions, easier to explain recovery to patients, and frankly, easier to catch mistakes before they turn into long-term problems.
Phase 1, the structural phase.
So phase one is the structural phase. And the first question in the structural phase is very simple. Is there a major structural injury here that we need to protect or fix? If a bone is broken, you cannot rehabilitate your way around that. If a tendon is torn badly enough, you may not be able to rehab your way around that either. If a joint is unstable, if a fracture is present, if there is a major soft tissue disruption, then the first order of business is not motion, not strengthening, not return to work. The first order of business is to identify that structural problem and address it appropriately. That may mean x-rays, it may mean a careful physical exam, it may mean ultrasound or MRI if the clinical picture is unclear. It may mean splinting, bracing, immobilization, referral to orthopedics, or surgical intervention. And sometimes that structural problem is obvious. If a wrist has a classic deformity, if a bone is visibly out of place, if a joint is grossly unstable, then the answer is sitting right in front of you. But often, it is not obvious. Sometimes a knee is so swollen and painful in the first 48 hours that every exam maneuver hurts, but none of them really teaches you anything. The shoulder is another classic example. The shoulder moves as a unit. Everything in there likes to move together. And if the whole thing is inflamed and angry, you can provoke pain very easily without actually isolating the injured structure in any particularly meaningful way. So, in those early cases, sometimes the best medicine is not to force an exam that is not going to be educational. Sometimes the best medicine is to protect the joint, reduce inflammation, give it 48 to 72 hours to calm down, and then come back for a better examination.
Which is less dramatic than many people would prefer, but considerably more intelligent. Human beings do love the fantasy that every answer should arrive instantly, preferably while poking a swollen joint hard enough to offend it.
Right. A painful exam is not always a useful exam. There is a difference between proving the patient hurts and actually learning what structure is injured. So in that structural phase, you're asking, is there a high-risk injury here? Is there something that requires more than conservative care? Is there something that has to be repaired or protected before rehab can even begin? And that phase can be short or long. Sometimes the structural phase is just 2 or 3 days while you let a joint settle down enough to assess it properly. Sometimes it is weeks. If a patient has a fracture, that structural phase may last until that fracture is healed enough to tolerate motion. If somebody has a rotator cuff tear and they need surgery, then the structural phase includes the diagnostic workup, the approval process, the surgery, and the early postoperative period where those tissues need to knit down enough that it is safe to begin movement. And that is an important point. When I say the structures are addressed, I do not mean they are fully healed. I mean they are healed enough or stable enough to begin the next task.
So one is not waiting for perfection. One is waiting for adequacy. That seems a useful distinction.
Exactly. We are not waiting for the shoulder to be normal. We are waiting for it to be stable enough to start restoring motion without causing harm.
Phase 2, the motion phase.
Once structures are stable enough to support movement, we enter phase 2, which is the motion phase. This is where physical therapy, occupational therapy, passive motion, stretching, home exercise, mobility work, and neuromuscular retraining become central. And this is usually the longest phase of recovery. For most injuries, especially the ones we spend the most time managing, this is where the bulk of rehab lives. Because after injury, the problem is not just weakness. The problem is stiffness, guarding, inflammation, altered mechanics, pain avoidance, and neuromuscular dysfunction. Patients stop moving normally. Tissues tighten. Joints lose range. Muscles stop firing in healthy patterns. The body starts building compensations. So phase two is the process of moving through dysfunction to get back to function. And that is often uncomfortable. There is a real misconception patients sometimes have, and frankly, sometimes clinicians do too, that if rehabilitation is working, it should feel steadily better from day one. But motion recovery often does not feel that way. It is often slow, it is often sore, and day to day, it can feel almost flat. You may not wake up each morning and think, wow, I am dramatically better than yesterday. You may actually have good days and bad days. And that is why longitudinal follow-up matters so much, because the provider and the therapist need to be able to step back and say, yes, this is uncomfortable, but the trend is improving. Or no, this is not moving the way it should, and we need to rethink what is happening.
This is the portion of recovery that patients tend to find a bit alarming, frankly, because they expect a heroic upward arc, and instead they get incremental progress, intermittent soreness, and the vague sense of wandering through a tunnel with poor lighting.
That is exactly right. Phase two is rarely cinematic. It is usually iterative. You stretch tissue, you cue movement, you teach mechanics, you repeat, the body relearns. Sometimes it learns new mechanics entirely. Take a repaired rotator cuff. That tendon may not pull exactly the way it used to. It may be shorter. Its tension relationships may be different. So the shoulder has to be taught how to move again. That is not a matter of brute force. That is repetition, cueing, motor patterning, and time. And again, shoulders are one of the best examples here because they are one of the longest joints to rehabilitate. The length of rehab often has a lot to do with the amount of motion you need to recover. The shoulder has a tremendous range of motion across multiple planes, so to get somebody back to a comfortable, functional shoulder can take months. 12 to 24 weeks in that motion-heavy phase is not unusual, especially after more significant injury or surgery. And notice I said functional motion, not necessarily normal motion. That matters because in many injuries, especially more substantial ones, returning somebody to textbook normal may not be realistic, and it may not even be necessary. Our goal is not always to create a perfect joint. Our goal is to create a joint that supports the function the patient needs for work, for life, and for play. For the shoulder, that often means enough forward flexion and abduction to comfortably function overhead, and enough internal rotation to do ordinary daily tasks without awkward compensation. If you can pat the top of your head without having to duck sideways and contort, you are usually in reasonably functional territory.
Not a glamorous benchmark, perhaps, but practical. Medicine is often at its best when it resists theatrical standards and asks the far more useful question: can the person actually live their life?
Exactly. Function matters more than elegance.
So why isn't strengthening the first goal?
Now, that's a question patients ask all the time. And the answer is that if you strengthen aggressively before you have functional motion, you often lock in dysfunctional motion. Yes, there is some strengthening happening in phase two. If you move tissue, if you load tissue even modestly, you are giving it some stimulus. Muscles are getting some activation. Tendons and ligaments are seeing some load. But strength is not the primary goal yet, because as tissue strengthens, it also becomes harder to stretch. Muscles get firmer, tendons get denser. The system adapts to the range it is being used in. So if you aggressively strengthen before you have an adequate arc of motion, what you risk doing is setting that limited motion in concrete. Now you have a stronger dysfunction. And that is a bad bargain.
Quite. One can build a sturdier house of cards, but it remains a house of cards.
Exactly. So the motion phase is about earning the range you need before you really chase strength as the dominant objective. And the amount of motion you need depends on the person. Somebody who needs to get dressed and reach shelves at home needs one level of function. Somebody who has to lift heavy equipment overhead, wrestle livestock, or perform physically unpredictable work needs much more. So your rehab target has to be tied to the real demands of the patient's life and job.
Phase 3, strength and function.
Once you have adequate motion, then you enter phase 3, which is strength and function. Now the goal shifts. We are no longer mostly trying to stretch the joint out. Now we are trying to make it strong, stable, durable, and task ready. This is where strengthening becomes direct. This is where the loads go up. This is where you start working not only on muscle performance, but on maintaining good biomechanics while under load. Because that is the key. It is not enough to get stronger. You have to get stronger without falling into bad movement patterns. If a shoulder starts impinging under load, if a back starts overextending under load, if a patient starts compensating through the hips or spine because a knee is weak, then you are just replacing one problem with another. So phase 3 is about strengthening while preserving good mechanics. And once those mechanics are solid, that is when function can really accelerate. This is why recovery often feels very slow in phase 2 and then suddenly picks up in phase 3. Motion recovery is often flat and linear. Strength recovery, once the mechanics are there and the tissues are ready, can feel much more exponential. You hit an inflection point. A patient suddenly says, now I actually feel like I'm getting somewhere. And that is usually because they finally have enough motion to build on.
So the second phase is laying track, and the third phase is finally running the train.
That's a good way to put it. And this is where work-specific and sport-specific function start to matter. If somebody needs to lift 100 pounds overhead at work, then at some point, rehab has to begin approximating that demand. Not all at once, obviously, but progressively, rationally, and with good supervision. You may start with a box lift at 25 pounds. You may work on positional tolerance, repetitive loading, dynamic stabilization. You gradually build the system up to meet the real-world task. And in otherwise healthy adults, once the motion and mechanics are in place, you can often rebuild a meaningful amount of muscular strength in about 6 weeks. Not perfection, not final form, but enough that the patient starts to feel strong again. That is the phase where we are thinking about advancing work restrictions, returning to play, increasing load tolerance, and moving toward maximal function. And ultimately, that is the end point. Back to work, back to sport, back to life, or as close to that as the injury allows.
So what do you do when someone isn't progressing through the phases or progress stalls?
That's the other reason I like this three-phase model. It helps you troubleshoot when a patient stops progressing. If somebody is not advancing in phase 3, go look at phase 2. Do they actually have the motion they need? Do they actually have the mechanics they need? Are they strong in a healthy pattern? Or are they just pushing load through compensation? And if somebody is not advancing in phase 2, go look at phase 1. Do they actually have stable enough structures to support rehab? Did we miss something? Is there a tear, an occult injury, an instability pattern, or a pain generator that is preventing them from getting motion back? This is one of the most common mistakes I see in transferred care and in prolonged claims that should have been much simpler. A provider gets attached to the initial diagnosis. They overtrust the first impression. They overtrust even the first imaging. And they stop asking whether the patient's progression still makes sense. But progression is data. If a shoulder is not getting its motion back after focused rehab, that means something. It may mean the therapy approach is wrong. It may mean pain control is inadequate. It may mean the physical therapist does not have the right skill set for that particular shoulder. It may mean you need adjunctive treatments like manipulation, massage, dry needling, acupuncture, a nocturnal muscle relaxant, an NSAID, or a corticosteroid injection to reduce pain enough for the patient to participate productively. Or it may mean you missed a structural injury. And that is the big one. Maybe you thought the rotator cuff was intact enough to rehab. Maybe the initial exam did not show high-risk findings. Fine. That was a reasonable starting point. But if the patient then fails motion rehab, you have effectively performed diagnostic physical therapy. The failure to progress is telling you something. Now it may be time for ultrasound. Now it may be time for MRI. Now it may be time to ask whether that partial tear is more significant than you thought, whether it progressed, or whether there is another structural problem preventing recovery.
In other words, when the house becomes wobbly, one does not merely redecorate the top floor. One inspects the foundation.
Exactly. And if you find a structural problem, then you restart the algorithm. Back to phase 1. Address structures, then return to phase 2, then phase 3. That is not failure. That is good medicine. The last thing I want to emphasize is this. When a patient is not progressing, you should be very cautious before deciding that the problem is simply the patient. Sometimes engagement is an issue. That is real. Some patients do not buy into movement. Some people culturally or personally believe that injured tissue should only rest and that motion is harmful. And in a lot of cases, that belief is just wrong. Appropriate movement improves healing. Appropriate loading improves function. If you do not use it, you do lose it. Now, that does not mean reckless loading. It means thoughtful loading. Decrease the offending movement. Protect what needs protection. Increase the rehabilitative movement. That is how you restore function. But even when patient engagement is imperfect, the clinician still has to ask, do I have the right diagnosis? That is the key question, because what I have seen many times, especially in workers' comp, is a case drifting toward an unnecessary mess because somebody stopped reassessing the diagnosis in light of the patient's progression. They keep treating the same assumed problem while the real problem evolves or reveals itself. A partial tear progresses. A repeat injury occurs. A new pain generator emerges. A secondary diagnosis is actually driving symptoms. And because nobody stepped back and reran the algorithm, the patient ends up at MMI with the wrong restrictions, the wrong impairment, the wrong conclusion, and a worse long-term outcome. That hurts everyone. It hurts the patient because they remain disabled. It hurts the employer and insurer because the claim becomes longer and more expensive. And it hurts the integrity of the medical process because the care is no longer matching the reality of the injury.
There is also, I should think, a certain professional vanity in refusing to revisit one's first conclusion. A tidy initial diagnosis can become rather beloved, even after the facts have begun gnawing at its ankles.
That's exactly right. Sometimes providers fall in love with the first story that made sense, but if the patient is not progressing the way that story predicts, you need a new story, and sometimes that means expanding the differential. Maybe the patient's ongoing shoulder pain is not actually shoulder pain. Maybe it is cervical radicular pain referring into the shoulder. Maybe they had a separate event, a car accident, something unrelated to the work injury, and now the symptom picture has changed. In workers' comp particularly, that matters a lot because causality matters, liability matters, the appropriate system for treatment matters. If the problem has changed, or if another diagnosis is now the real driver, you need to identify that. Not just for claim management, though, that matters. Also for the patient, because you do not want them sitting in the wrong treatment lane while their actual diagnosis goes unattended. That broader issue of secondary diagnoses and layered causality is its own conversation, and frankly, a large one. But the basic point here is simple. If progress stops making sense, expand your thinking before you close your chart. So to sum it up, injury rehabilitation usually makes the most sense when you think about it in 3 phases. Phase 1, structural. Make sure nothing major is broken, torn, unstable, or otherwise in need of protection or repair. Phase 2, motion. Once the structures can support it, restore functional range of motion, restore mechanics, and move through dysfunction. Phase 3, strength and function. Once motion is adequate, build strength, build endurance, build load tolerance, and return the patient to the actual demands of work, life, or sport. And if the patient is not progressing, go back 1 phase and ask what you are missing. That, in my view, is one of the cleanest ways to think about rehabilitation without getting lost in the weeds.
A pleasingly orderly framework. Bones first, then movement, then strength. One likes a sequence with some backbone to it.
That's right.
Also, for the record, both orthopedics and dogs remain deeply invested in bones, though admittedly from rather different philosophical angles.
Fair enough.
And if your rehab plan consists of doing absolutely nothing and hoping the tissue sorts itself out while you stare at it like a distracted squirrel in traffic, that is probably not a sophisticated medical strategy.
That is also fair. So that's the episode. If you like this kind of content, follow along. We'll keep doing more on injury care, rehab logic, workers' comp, and how to think clearly when musculoskeletal recovery stops behaving the way it should.